Thank you very much for the opportunity to come and speak here today. It's a real honor and a real privilege to be with you in Sydney. So I must say I'm extremely excited about the invitation. So thank you to the organising committee. Now, when we look at the title of this, and before we get into it, it's important that one makes it clear that I have in the past had some consultancy and speaker fees from the following people, but none of the work that I'm going to present today has been in any way funded by these people, and that's important as it pertains to our group in Cork. But if we take back and we step back and we look at the title of this talk, The Evolution of CF Management and What the Future Holds, what you will realise is that I have essentially two roles here today. On one level, I'm meant to be like the Spanish-born American philosopher George Santayana, who basically said that those who cannot remember the past are condemned to repeat it. And so my job is to go through the evolution of CF care, highlighting things for you. And then my job is to be like Sybil Trelawney in Harry Potter, as a professor of divination, who will basically say that one does not parade the fact that one is all-knowing. And that's obviously when I talk about the future. So forgive me if I don't get that one right. But if we think about the journey, we remember that it started in the 30s when Dorothy Anderson described this as a disease involving the pancreas. We know that Francis Collins and company by the late 80s, early 90s described the gene. 20 years on, the boy who was on the front cover of Science was a man holding the same journal with the same disease. And now we've got to a point where groups like mine write review articles called Cftr Modulation, the end of the beginning. Because in essence, that's where it is. It's at the end of the beginning. And that is, in some respects, the evolution. When we think about where we have evolved to, I would make reference to papers, and I had a great opportunity to write with your colleague Scott Bell on this. And what we showed, looking at American registry data and looking 30 years apart, is you can see that there are far more adults with cystic fibrosis now than there were 30 years ago. Equally, we can see that we've evolved into a situation where even those who are 30 years and older, over 70% of those will have moderately impaired lung function or normal lung function. So this is a very positive evolution. So why has this happened? Some would say it has happened because of incremental, modest benefits all along the way. Enzymes, physiotherapy, inhaled antibiotics, up to the next generation therapies. People would say that within this, though, there's been a single-mindedness, or as I was coming down here, I felt we would call it a bloody-mindedness. But it is important that this is a slow, incremental development and evolution. You see, we in cystic fibrosis have always had a sort of a futuristic approach. And if we're to be honest about it, CF providers and healthcare practitioners are not particularly happy people. They're never really that satisfied. And that's why in 30 years, the survival has increased by 30 years. Because in essence, the mantra is, if something works, make it work better. If something doesn't work, make it work. And then when you've got to that point, it's about Wednesday or Thursday in your week, you go, hold on a minute, now we've got a whole new problem because we've made the first two things work. And then finally on Friday, when the cardiologist is going home to tell his wife about all the people that he saved that week, the CF provider, on the other hand, goes home and says, do you know, I've been thinking about it, we've been doing this wrong the whole time. And that's the reality of the evolution of CF care. And you can track this through inhaled antibiotics, Cftr modulation, extrapulmonary CF, and ultimately in that baby that I call CF Matters. And so I'm going to give you some examples around that very briefly and quickly, unfortunately. So first of all, what we know is that as you live longer, you're more likely to acquire Pseudomonas. And then when we look at the evolution of the therapies, we think of people like Jim Littlewood in Leeds, who used IV coleomycin nebulized as an inhaled antibiotic. It evolved into more sophisticated studies like Bonnie Ramsey's with inhaled tobramycin. And when we think about it, at the time she said in this particular paper, which is old now, all about reduction in IV antibiotic usage. And it took another 11 years for D.B. Sanders to point out to us that that evolution was critical, because if you can prevent exacerbations, you can prevent the probability of an individual not returning to their pre-exacerbation state, because you have a 1 in 4 chance of this happening. So in inhaled antibiotics, though, it also evolved that it took an awful lot of time to do these things. And the burden of disease now, Gregory Sawacki, in a very elegant paper in JCF, highlighted 108 minutes a day in kind of airway-related therapies. And that's not including cleaning your machine. And so in reality, when we're in this situation, what do? Well, we say, great, let's just give it quicker. Let's just find a way to give this thing quicker. And so we do. And we have 2 ways of doing this, or 2 examples I'm going to share with you. One is you use the same drug with a new delivery system. The other is you use a new drug with a new delivery system. But there's one important point. Clinical trials have no authority on adherence. This is very important because they have to be adherent for the trial to get published in the first place. And so it's speculation on their part. You need real-world studies to determine it. Equally, when you bring a new drug on the market, you might get it licensed for one thing, but how do we really use it in our clinic? And so I'm going to show you briefly in relation to these. So we know that the EAGER study showed that the pod inhaler in tobramycin was equivalent to inhaled nebulized tobramycin. And people said, oh, well, that'll mean people will use it. But will they? We were very interested in this in our clinic, and we'll go into detail about this later in the week. But what we developed was an adherence score. So you were very good if you did it 80% or more. You were pretty good if you did it 50% or more, and you're no good if you do it 50% or less. And just to summarize, the key finding here is that the patients went from about 40% of them on a long nebulizer to basically 80% on a rapid delivery system. So a rapid delivery system does appear to enhance adherence in a self-reporting environment. So that's the issue. And that translated in our clinic into decreased IV antibiotic usage prospectively in this cohort. So it appears to be working. But that has its flaws and limitations in that it's a single-center study. So what about multi-center studies around these questions? Well, we know about inhaled nebulized Astrianum, and we know that this drug is meant to be equivalent to tobramycin. So do we use it in an equivalent fashion? That's how it gets its license. That's how it's here. But how do clinicians actually prescribe this? And so some of these people will be familiar to many of you, some of my colleagues in Ireland and the United Kingdom. We basically all got together and we decided to look at the year before and the year after we started using this particular rapid delivery system and new drug to see how we used it in our clinics. And what we basically showed were 2 interesting things. First of all, they're a more severe clinical phenotype than the ones that were in the clinical trial. So we don't give it to the ones in the trial, we give it to people that were sicker. I mean, the median FEV1 was 36%, in the trials it was 55%. We see more diabetics and more females. So we're giving it to a sicker patient, not an equivalent patient. Secondly, what makes us give it is that in this year before, these patients are actively declining. And in this situation, they seem to improve after the intervention. Now, this translated into reduction in IV antibiotic and hospital days, but it's important to highlight that we don't know whether someone took this drug or not because we weren't in a position to measure it. All we know is the intervention of using the drug changed the pathway in these patients. So I think you can see that we are basically saying if something is working, make it work better. Now, something doesn't work. Then you've got to try and make it work. And in relation to that, we're really about Cftr modulation. And what we've learned to appreciate is that CF is not one genetic condition. There's nearly 2,000 different mutations. However, at the same time, you can split it down into 4 basic sort of types. You've got gene therapy, which is a one-shoe-fits-all. You've got the read-through agents, CFTR potentiation, and CFTR correction. We can then classify by the CFTR defects, and we've got 6 different classifications now. And in essence, this allows us to target these pharmacologically, as you can see here. Now, we know that in essence there are therapies for 2, 3, and 4 at this point in time. However, I think in the interests of time, I'm going to focus on Cftr, the one that we have most information on, because I think it'll tell us how we're evolving, as it were. So we need to understand CFTR modulation because we need to benchmark it, as it were, so that we can have a mechanistic appreciation of what's going on, so that we can target it for the future. And we know, obviously, from the work from Fred van der Goor and co., that there's an increase in the probability that the chloride channels will function. We know about STRIVE. It was a seminal paper, and that the lung function went up by over 10%, and the exacerbation rate went down, and weight went up, and sweat went down. You this biomarker. We're all very familiar with this data. But if you stop at that point and you say to the people who wrote that paper, I just have one question for you, and they'll say, okay, but just before, I just want to tell you how on the back of that we were able to get it licensed, and we now know that we use it in X, Y, and Z and in gating. And then you turn around and you say to them, but how does this drug work? And that's the point. How does it really work? We have to start thinking about that. We have to evolve our thinking, as it were. Now, this guy hasn't a clue how that car works, but nonetheless, he's willing to look, and most of us are exactly the same. I think if we look at the real-world studies, we can get some bit of a signal. The GOAL study, which is a real-world study, has shown us a couple of things. It's shown us, first of all, that in the real world in the United States, it doesn't work as well in relation to lung function as it did in the clinical trial. That was their finding, not everybody's, but theirs. But they had a signal around Pseudomonas, which needs to be explored more. And Pradeep Singh, I know, is going to talk about that more this week as well. They didn't see a change in cytokines from the point of view of the sputum. However, we should be cautious about this because there were 14 sputums from 5 sites. And there was a total of 29 sites. So there's a dilution and a noise here that multi-center studies have no choice but to have. And so there may be some emerging issues around these things. What they showed, which I thought was very exciting, was this issue of improvement in gastric pH. Maybe this is part of the solution, as it were. But the problem that they have, and the problem that we face as a community internationally, is because of the frequency of this mutation. In essence, you're almost obliged to have multi-center studies and multi-center noise. However, I apologize there, this is moving on slightly faster than I thought. However, in relation to our own unique position in Cork, for reasons that are unclear, basically 23% of our population actually carry this. And so we've studied 33 of them in close detail, and I'm going to tell you about that. Before I do, I suppose I want to put that in context. We have 51 patients with the G551D mutation on our campus. That is more than they have in France. And as we had a rugby theme earlier today, I think it's important that we highlight we have a crunch game against France in a couple of weeks in the World Cup. And Cftr is on our side, not on the side of the French. Okay, so getting back to this, we basically were looking for a mechanism that might explain this. So first of all, our cohort are a responding cohort, because you have to study a group that responds to understand a mechanism. And what do I mean by that? They pretty much did what STRIVE did, with a sort of a 10% improvement in lung function, etc. We also showed a significant increase in shuttle walk test, a decrease in antibiotic usage prospectively by 76% over a year. But what was really interesting, and I suppose in a way this is us being Australian, we got into low-dose, high-res CT scanning on our patients, and we did them prospectively every 3 months. And what we showed in our cohort is that the total BALA score went down, but particularly in the areas of peribronchial thickening, it goes down at month 3 and stays down, extent of mucus plugging and collapse and consolidation. We do not see bronchiectasis going away. We see enhanced mucociliary clearance. And this would be an example here that you can see a before and an after in the same individual, and obviously the right middle lobe here is radically better and you get a decrease in the mucus plugging. And at the end of the day we highlight some things are not amenable to ivacaftor with a residual change on this side. We also saw a reduction in inflammatory cytokines in our cohort in peripheral blood. And so our belief is that the mechanism is really around enhanced mucociliary clearance. And this is what's driving it, and everything else is a sort of a downstream effect. That's our hypothesis. So it doesn't work, make it work, and then try and understand why it works. This is the evolution of CF care and the future of CF care. So it's worked. You've now got a new problem on your hands. And again, in relation to these new problems, you can use the big list. This would again, I refer to the work we did with Scott Bell. Now, the bits in this particular paper that were written by him are absolutely fantastic. Now, the bits written by the rest of us are somewhat questionable. But I would say that the things to think about are like cancer, arterial access, drug resistance. But I was asked by Peter to talk about the evolution of CF. And so if we think about the evolution of CF, well, it was a GI disease. We treated the gut illness, it became a pulmonary disease. But in reality, maybe we're going back to the future, as it were, and back to the gut. Because at the end of the day, embryologically, the lung and the gut are from the same place. And we know that there's a significant interaction between them. We know that bacteria can presage the gut that ends up in the lung, that the inflammation in the gut can cause inflammation in the lung. And this is this concept of the lung-gut axis. And so in essence, in relation to this, what we get is this concept of recurrent lung infections, changing intestinal microflora, and this ultimately having a negative feedback. So we thought we should explore this in some way in our group, and we started doing this by looking at something simple like Clostridium difficile. And so in relation to Clostridium difficile, what do we know? And what we know is if you study the papers as they're published, it seems to be going up over time. The asymptomatic, and that's the other very interesting finding, of Clostridium difficile and CF is going up over time, almost as our IV antibiotic usage is going up over time. And so we decided we'd look at it in our clinic. And again, we'd look at it just prospectively in asymptomatic carriers, but we also wanted to look at it at a level that hadn't been looked at before. A little bit like non-tuberculous mycobacteria. They're not all the same. Neither is Clostridium difficile. That is an overriding label for something that's far more complex. And so in relation to that, we basically looked at it in relation to culture, and then ultimately we sequenced looking for toxins and ribotypes, etc. So what did we see in a standard 60 patients coming to our clinic that had no GI symptoms? First of all, half of them were asymptomatic carriers of Clostridium difficile. 1 in 2 walking into the clinic had Clostridium difficile. This is the highest incidence of it reported to date in the literature. When we looked at the ribotypes and the toxins, we could see that of the half, 63% of those produce toxin. And that was confirmed on ELISA. But then when we look at the ribotypes, we see that there's 15 different ones, so all C. diff is not the same, 11 of which have been described as disease-causing. And more importantly, we saw hypervirulent strain in this population. So then we go back to this concept of who are we protecting who against? The evolution of CF care has been protect the CF patient from all those other nasty patients that are in the hospital. But maybe now the reality is that the shoe is on the other foot, because we know that in studies done, nosocomial acquisition of Clostridium difficile is often got from asymptomatic other patients on the same ward. And so in reality, what we did was we looked at the ribotypes that are most common in Irish healthcare, and we went to see were they in our CF population. And they are. And so this raises the question that we should be isolating and protecting the general patients potentially from the CF patients, and the importance of hand hygiene around when you're seeing your CF patient before you see your non-CF patient. So we're evolving our thinking to go beyond CF, as it were. They're fairly sensitive, so that's the one positive, that you can treat these easily. Equally, this concept of the lung infecting the gut, Fiona Fouhy, who works with us, she's a very elegant scientist, has taken this work to the next level, to the microbiome. And just to show you a snapshot of some of the work that she presented at European CF, and what she basically showed was the more diverse your gut microbiome, the better your lung function. So this concept, now there are confounders to all of this, but this concept that you may be what you eat, or that your gut determines your lung function, is a very important finding as we move forward and go back to the future. And it raises the question around the use of probiotics. Again, there's been 2 small pilot studies. Lots of people use them, and I think we need to think more about them. So it's worked. It hasn't worked. We've got a new problem. And then it's Friday, guys. You're meant to be going home. You're meant to feel good about what you've done in your CF care. But you look at this graph and you say, because you've been fed this graph from the first day you did CF medicine. You're used to seeing it. Pseudomonas goes up. And then you sort of rumble through some documents on your table and you stumble across a paper like this one from Michael Tunney, and you realize that he's able to grow anaerobes in 64% of his patients. And then you go, where are they on the graph? No one has put them on the graph. They don't exist. They're not here. And you say to yourself, well, why is this? And it's the realities of CF care. If we don't look, we don't see. So then you go into one of your patients, you're feeling a little bit low, and they say, you're not yourself today, Dr. Plant, what's wrong with you? And you say, well, if you don't look, you don't see. And they say, that's kind of profound. And you say, I'm having a Bob Dylan moment. They say to you, who is Bob Dylan? You may laugh, but this is important. Because what you actually say to him is Bob Dylan is Jacob Dylan's dad. And they know who he is, because he's the lead singer of the Wallflowers. He is the next generation. And this is important, because if you do apply next generation technologies to examining sputum, you see things that you don't see if you just use standard mechanisms that have been in place for years. And we've done this. This is work that Kate Toomey did with us, and loads of people have done this. You take a load of sputum, you culture it, you get the usual suspects. Then you use next generation technology and you use the microbiome. And when you use the microbiome, you see this taxonomic diversity that's just immense. And then if you break it down into genera, you find all these things there that we don't know whether they're good or bad, whether we should treat them or not. But they are there, and they're not in the graph. And that's the important point. And so then we think back and we realize a lot of them are anaerobic, and this relationship between the lung and the gut and the lung-gut axis. And this is in essence where CF Matters comes in. And so in relation to CF Matters, what CF Matters stands for is Cystic Fibrosis Microbiome-Derived Antimicrobial Therapy Trial in Exacerbations, Results Stratified. It nearly killed us to come up with it. But this is important. This is important because as a result, we've had the opportunity with the EU funding to set up an international collaboration where what we are doing is we're running a randomized control trial of 252 patients across 7 clinical sites, and they'll basically either get a standard therapeutic arm or a microbiome-determined, consensus-driven treatment of their next exacerbation. And simultaneously, there will be a whole load of lung, gut, animal model, etc., parallel studies to try and understand mechanism. And this is currently active as we speak. The sites, you will recognize many of these, including our collaborators in Queens and in Seattle and Paris and lots of other European sites. This is us, and again, you recognize some of the usual suspects here. Enrollment is ongoing. We're at about a third the way on, which is super. Some sites are getting close to the finish line. That's us, because we have to. But in essence, we'd ask you to Google us and look us up, because all of this will be put online fairly quickly because of the EU's approach. And hopefully it'll answer this issue about whether or not, or at least contribute to it, microbiome approach is the way forward. So I'm going to conclude now with my futuristic, what the future holds me as the professor of diviniation, and my predictions. And so the first thing that we must think about in relation to that is the work done by Pierre-Regis Bourgel in the ERJ this year. Because it has basically shown that in the next 10 years in Europe, and I suspect it's the same in Australia, the absolute number of CF patients will go up by 50%, and that will be 75% more adults as well. So we need more people working in CF, we need more expertise in CF, and we need infrastructure built for CF if we are going to be able to deal with CF into the future. That's my first prediction. My second prediction is, how are we going to deal with all the n=1 studies? How are we going to determine for all those people that don't fortuitously fall into a nice classification system whether a drug is good or not for them? I think there's a load of elegant work coming out at European CF this year. There was a real buzz around the whole organoid technology, and I think this is a place that we will be going, as it were. We will be creating mini-me, the organoid, as it were, to answer these questions, and it's very exciting. When you have this and you have this, you're going to have this. It's going to cost. And I think, fortuitously, we'll be addressing that in the next part of this afternoon, and so I won't deal with that. I'm going to close with, to me, one of the greatest philosophers to come out of Australia. I'm actually serious about that. And I think about one of the things about CF and the future and the past, and actually Nick Cave actually probably summed it up very well. He may not have realized it at the time, but it's almost 20 years from when he wrote the song "People Ain't No Good." And it's just a very human song that highlights the human condition. And I love my patients with cystic fibrosis, but there are some of them, and they just will never take anything. They just won't. Adherence was an issue 20 years ago. Adherence will be an issue 20 years from now. And that is the human condition. So my final prediction is we'll be talking about adherence forever also. So finally, I'd just like to say I work with an amazing group of people, both locally and internationally, and I'd like to thank them all, because without them, I wouldn't be here. Thanks very much.